we're talking about somewhat aggressive approaches in the curative intent setting. But Viktor, how do you balance the efficacy of these aggressive approaches with the long-term toxicity? And tell us a little bit more about the long-term toxicity that you worry about.
Yeah, so I think talking about aggressive therapy, it really is, you have to think careful about the patient, because we imply toxicities that are certainly acute during the course of treatment, and requirements of feeding tubes and etc. I mean, it's something you do initially, and then what we have seen with the long-term follow-up of the RTOG studies is that there are more and more patients, they have more patients dying on the aggressive approach doing the radiochemotherapy than compared to radiotherapy per se. So why is that actually? So there's some long-term toxicity that is coming probably from problems, local problems, swallowing problems, and we have to take that into account and to really look into the patient and see whether is that the one that could get to the point where we could have an early detection and of side effects that may occur. So that, because usually it's once they're cured, they're on their own, and they have to be sophisticated enough to come in if there are problems, and so you solve them quickly and early.
Yeah, and some of these patients can suffer quite a bit from the long-term effects of the treatment. Tanguy, let me ask you the same question. How do you achieve that balance? And take me through your thought process for that.
I mean, I think we hear it again and again, and I agree with the prior comments. There is a clear balance between toxicity and efficacy of the treatment. And I think now that we have different subgroups of patients, at the most highest level, HPV positive and HPV negative, but then also, HPV smokers and maybe some molecular features. I think we're starting to realize that maybe we can adjust the treatment a little bit. So people have mentioned already, my Kevin and Viktor, that there may be an opportunity for patients who have a really good prognosis despite stage, so HPV positive tumors, that we can actually give less treatment. We can go down potentially on the dose of radiation to 60, or we've actually just completed a study going down to 45 gray, and that actually seems to work. And I wouldn't say that this should be done as routine standard of care. I think it's a very cautious approach. We have to monitor this carefully. But clearly, we are likely over-treating a significant fraction of HPV-positive tumors. And I think getting that right is something that I think large centers have to do in a very controlled fashion as part of clinical trials. So I think that balance is different for HPV-positive tumors that have a better prognosis from some of the HPV-negative tumors. On the other hand, some very poor prognosis HPV-negative tumors, we're talking about intensification. Maybe in those groups we should add on additional things. And I think we'll talk about neoadjuvant chemotherapy, which is clearly controversial, but maybe in patients who had really high risk for distant failure with poor prognosis, that's something to consider. And it's not necessarily standard of care, but it is considered reasonable to do. And so we will discuss those factors. So I believe that de-escalation is likely going to be successful, but right now it should still be done as part of clinical trials. So I hope that answers your question, at least in part.
So your center, along with others, is looking at different ways to de-intensify therapy for HPV-positive patients. But what I'm hearing you say is you're not doing that outside of a clinical trial.
Yeah, I think it has to be done with a lot of caution as part of a clinical trial. The clinical trial is essential to monitor because obviously these are patients who are almost universally curable, and we don't want to de-escalate to a level where potentially we lose that ability to cure. So I think doing it as part of a clinical trial is essential, and there's usually great safeguards built into the trial. So I think de-escalation should only be done on a clinical trial until we have large-scale data. And one effort is by the RTOG 1016 study that actually replaces cisplatin with cetuximab, and we don't have those data, so I wouldn't do this outside of a clinical trial currently.
And I know the UK, there are some efforts going on along those same lines. Kevin, I don't know.
So we have a study that essentially mirrors the design of the RTOG 1016, the so-called de-escalate protocol, in which cisplatin is replaced by cetuximab during radiotherapy for patients with HPV-positive disease. In addition, there is a re-emergence of an evaluation of the role of surgery, and that's not just in the UK, that is also Tanguy will know this, and also elsewhere. Christian Simon in Europe is well looking at these sorts of approaches. And the question there is really whether or not a surgical approach to remove the primary tumour with or without lymph nodes may yield pathological information that allows you to deliver either a lower radiation dose or omit platinum as part of adjuvant therapy, which of course will have a downstream beneficial effect for patients. So I think that all of these things are on the table, and I think it's reassuring for patients to know that their doctors are looking at all of the three major modalities: surgery, radiation in terms of reducing dose, reducing field size, and also the use of cisplatin-based chemotherapy with replacement by cetuximab. And then, of course, something that we will discuss a little later, potentially also the role of immunotherapy agents that might indeed be able to supplant the role of cisplatin-based chemotherapy in this setting. So I think patients should be very reassured of the fact that all three of the major groups of clinicians looking after them are engaged in what I think you could think of as an arms race to find the best treatment approach for their patients.